Welcome to week 2 of Introduction to Medicine and Healthcare. This week we'll be talking about current healthcare system and trends, as well as therapeutic and medical interventions, both from the perspective of single, individual, patient, and group sessions. And of course, the third big area is infection control. Now, I would like to start with this specific topic because if the question arises, what is infection control? What's the purpose of infection control? Well, the purpose of infection control is to monitor, detect, and appropriately react to infection diseases. So this will be the first topic of this week. Without further ado, let's begin. So if we want to prevent an infectious disease, we have to have a clear understanding of what infection diseases actually are. So an infection disease is really any disease that is caused by the growth of pathogens, these microorganisms. And so they are very, very important. And the study of microorganisms is microbiology. Again, if you remember what we said about medical terminology, microbiology is a compound. It's a word that in Greek means micro, of course, so very small. Bios, which is life, and of course logos, logi, which is the study of microorganisms in this case. Now this is a fundamental concept because it's related to quite a debate in the old days of modern medicine. So we're talking about 17th and 18th century onwards. We can think of names like Pasteur, for instance, from which the term pasteurization was made popular. And the germ theory of disease, especially the German-Prussian component within the germ theory of disease, and eventually the French, Italian, and British counterpart. Now, within the germ theory of disease, the idea is that there are diseases that are indeed caused by the presence and activity of such microorganisms. Now, as you can imagine, in a time where microbiology wasn't really a field and population health and safety measures, including health-related practices focus on personal hygiene and environmental hygiene. Now, in those times, the very element that was the causal factor for this type of infectious disease was completely misunderstood. And this stems from the very notion of the importance of washing one's hand before any medical procedure, for instance. So again, when we talk about the germ theory of disease, we're thinking about the theory that eventually was proven to be the correct one, that diseases of this kind are indeed caused by the presence and activity of such microorganisms, those germs in our bodies. Now, talking about biology, we have to understand what microorganisms are. So microorganisms, as the name implies, are very small, usually one-celled living plants or animals. They are found everywhere. Another important factor to better understand microorganisms is that we can distinguish between aerobic microorganisms that require oxygen, aeros, air in Latin, versus anaerobic microorganisms that do not require oxygen. Wonderful, but what about microbes? We talk about microbiology, right? So what about microbes? Well, microbes are pathogenic microorganisms. So again, if we want to monitor the spread of these microorganisms, these germs in the human body, any healthcare profession, any healthcare institution really has to follow close procedures in order to provide the best possible care to our patients. Also, an important concept to keep in mind is that there are two main types of infections from the perspective of healthcare. There are generalized infections, also called systemic infections, and then there are localized infections. So let's see the difference in this slide. So as we said, infections are diseases caused by microorganisms invading tissues. And we have these two types, the generalized and the local infections. Just to give you a general description, a localized infection originates in and is confined to one organ system or a general area in the body. Examples are an abscess of finger or a sprained ankle. A systemic infection, instead, contrary to a local infection, spreads throughout the systems of the body. Another very, very important concept to understand how diseases occur and spread, how they manifest themselves, is the chain of infection. We will see this model in the next slide. So here we have an image, a chain of infection, the first part, and we have three different colors and shapes. The red color indicates the relation between the subject or patient to healthcare professionals, visitors, and other patients. The yellow color instead, it's the visitor, and you can see how this interaction occur with those arrows and the dotted lines. And finally, the third image and color are healthcare professionals in general. So it's really important to understand how this connection between these people are an essential part of the chain of infection, what actually causes the infection to occur and to spread. Let's continue with part 2 of our discussion. Important things to keep in mind. There are three things that are necessary for an infection to occur. Number 1, source. Number 2, susceptible person. And number 3, transmission. Now, the source indicates places where germs with these infectious agents live. As an example here, as far as human beings, we can think of the skin, or external surfaces like sinks, for instance. Number 2, the susceptible person, with a way for these germs to enter the body. And then number 3, transmission, one or multiple ways germs are moved to the susceptible person. There are different ways to describe the same concept, the chain of infection. One of these concepts is the disease transmission cycle. In this model, there are 6 components required for the spread of an infection organism to a susceptible host. Number 1, it's the agent, of course, the disease-producing microorganism. Number 2 is the reservoir, the place where the agent lives. So again, us, humans, animals, plants, soil, air, and water. Number 3, the mode of escape, which is also called the portal of exit, which is how the agent exits the reservoir. Number 4, mode of transmission. Number 5, place of entry. And of course, number 6, a susceptible host. So a slightly different way to describe the chain of infection. Keep in mind that, of course, each of these components must be present for the infection to be transmitted. Now, we talked about germs, so let's keep in mind that germs are not able to move themselves because they depend both for transmission, but also for their very survival on people, the environment, or medical equipment, right? But in general, when we think about healthcare, okay, healthcare facilities, healthcare environments, these germs travel through 1, contact, for instance, touching or rubbing, sprays and splashes, coughs or sneezing, creating droplets within about 6 feet, very, very important. 3, inhalation, and 4, sharp injuries, bloodborne pathogens, for instance, needles or scissors. Now, if you think about the hierarchy of infection control, we think about multiple ways to protect ourselves. Those are few examples that will be further illustrated. Number 1, our personal responsibility as healthcare providers to wear PPE or personal protective equipment, such as gloves and surgical masks. Number 2, the environmental engineering controls, as an example here, to reduce concentration of infectious bacilli in air in areas where air contamination is likely. This is an example that the healthcare facility itself has to implement. And number 3, at the higher level in terms of organization, of course, organization administrative controls to reduce risk of exposure, infection, disease, the appropriate policies and practices, the administration of a hospital, for instance. Now, we talked about hierarchy infection control within healthcare facilities. So we're talking about a very important concept, the HAI, down below here. HAI, it's an acronym indicating a healthcare associated infection, which of course is an infection that occurs in a patient as a result of care at a healthcare facility, which was not present, very important, at the time of arrival at the facilities. So in this table, I have listed the microorganisms causing the 4 main HAIs of global public health interest. On the left side, we see the description of HAIs, and on the right side, the very microorganism causing them.
As an example here, of course, again, the HHIs included here are central line associated bloodstream infection, surgical site infection, catheter associated urinary tract infection, UTIs, and pneumonia. Let's talk about the flora now. So we previously mentioned that in general, when we talk about microorganism, we indicate microbes as pathogenic microorganisms, right? So we also mentioned that plant and animal microbes are classified as bacteria, vira or viruses, fungi, rickettsia, and protozoa. Now, because of that, it's very important to understand that not every microorganism is dangerous to us or harmful. Normal flora, so the particular environment where non-harmful microorganisms reside, can be found, for instance, in our intestines and the skin. Some microorganisms are necessary for survival, so to maintain normal function, and there are many of them. One of the most common examples within healthcare is the E. coli or Escherichia coli, a non-pathogen aid for the digestive process in the colon. And then there's also some types of microorganisms that can be harmful only if the subject becomes susceptible to an infection, for instance, through the suppression of the immune system. Now, let's continue with the flora. There are two types of flora, resident and transient. Resident flora defines microorganisms living in the deeper layer of the skin and within hair follicles, which can be fully removed. And that means, even if you wash your hands very, very vigorously and you rinse them with soap and clean water. In most cases, resident flora are not likely to be associated with infections. However, the hands or fingernails of some healthcare workers can become colonized by microorganisms that do cause infection, which can be transmitted to patients. So very, very important to pay special attention to hand hygiene as a healthcare provider. Transient flora, instead, it defines microorganisms acquired through contact with individuals or contaminated surfaces during the course of normal daily activities. They live in the upper layer of the skin and are more amenable to removal by hand hygiene. They are the microorganisms most likely to cause HAI. Now, in terms of survival, we also have to think about the nutrition factors in connection to microorganisms. Some microorganisms obtain nutrient for their growth and reproduction from hosts, as we have seen before. Hosts, again, indicate living organisms. Now, think about this type of relation. So they need to obtain nutrient for survival and reproduction, right? So if this relationship between the microorganism and the host is beneficial to the host, it's called symbiosis. Now let's take a few seconds here to talk about medical terminology. When we think about symbiosis, we think about two Greek or Greco-Latin terms, sym and bios. Okay, sym really indicates the connection, the mutual exchange. In this context, mutual beneficial exchange, the combination. So the letter SYM, okay, or SYM, right, is the equivalent of the Latin cum, right, which means with, together. Okay, so something together, and of course, the second part of the word, bios, okay, bios, indicates life. All right, so a living element, a living being. Okay, so symbiosis, of course, a mutual connection, mutual relationship between the microorganism on one side and the host, which is also a living organism on the other side. So if it's beneficial symbiosis, if there is no effect, it is called, not surprisingly, neutralism. Okay, neuter, neuter, neither. Also, all these words are connected, etymologically speaking, from their Indo-European precursor. Indicate neither or, right? So neuter means that it does not involve type A or type C. So if there's no effect, it's called neutralism. C, if the microorganism obtain nutrients at the expense of host this time and causes them damage by doing so, it is called a parasite. All right. So again, they need to feed, they need to obtain nutrient to grow and reproduce. If they're beneficial to the host, symbiosis. If there's no effect, neutralism. And if they have a negative, a damaging effect, they'll be called parasites. All right, so moving on to precautions in general. Few things to keep in mind. There are many protocols that are beneficial in order to prevent infections. These are some of the most commonly utilized infection control precautions in healthcare. Starting from hand hygiene, we cannot stress this enough, how important hand hygiene is to avoid contamination, to avoid spread of infection. Number 2, again, PPE, personal protective equipment. Number 3, respiratory hygiene or cough protocols. 4, appropriate patient placement, because of course the healthcare environment plays a fundamental role in this context as well. For instance, choosing a single as opposed to a double room, what type of unit, what type of environment. Number 5, this is common sense, and yet we have to really pay attention to the cleaning and the disinfecting procedure of equipment and environment, bleach wipes and so on and so forth. Number 6, appropriate handling of textiles and laundry. So even if we're leaving the patient's room, it's really important to pay special attention to linens and any type of clothing garments that we're handling. Number 7, safe injection practices. Number 8, wearing surgical masks, for instance, during lumbar punctures, and depending on the situation during a pandemic, of course, wearing surgical masks it's very important. And in general, number 9, healthcare staff safety, for instance, in the context of handling sharps. To continue this discussion, I provide a few examples here. Wearing and removing surgical masks, wearing and removing gloves, wearing and removing stethoscopes, and just a few examples of hand sanitizers, which we'll see in a second.
How to properly remove contaminated gloves. So you want to make sure to reach out and grab the interior portion of one glove. You can flip it upside down so this hand will not touch the exterior portion of the glove, and then you will insert your thumb or finger into the glove that you still have on, and then you flip it upside down so that nothing touches the contaminated portion. You grab the glove, and then you will be able to discard the glove appropriately. Aside from the extremely important hand washing procedure, in modern times we also use hand sanitizers a lot, and those are just some examples that we utilize every day on the units at a hospital. There are different types of hand sanitizer, but of course it's really important to be able to use them properly. Of course, when we think about the importance of hand hygiene, we want to make sure to dedicate enough time to this procedure to make sure that we don't miss any part of our hands when we do this. And we should also select hand sanitizers depending on their specific ingredients, also following the rules and regulation of the healthcare facilities where we work to better prepare ourselves in the context of clinical and therapeutic modalities. Now, the same care, of course, has to be used when putting on a surgical mask. You want to make sure to have the corresponding nose parts on top and chin part on the bottom. And of course, with the same care, you will proceed to remove the mask and dispose it properly as recommended. So again, all these procedures are extremely important. Now, of course, we should also make sure not to touch ourselves, our nose, our lips, our hair unnecessarily. We should really prevent the spread of disease by virtue of unnecessarily touching parts of our body. And so this applies also to the way we utilize our stethoscope. Now, one thing to keep in mind is that people usually wear a stethoscope in different ways, but it's always important to keep in mind that the ear tips, all right, when you put the stethoscope in, the ear tips should look away from you, just like that. In fact, I have another one here that maybe shows this a little better. So the ear tips, the binaurals are shaped like this, like a V, as you can see here, shaped like a V, and they are shaped that way to match your ear canal. So you should put it on, keeping the ear tips away from you, right? Just like this, okay? Because if you do it the opposite way, if you do it backwards, not only you will not be able to hear well, but you also might hurt. And so you really want to make sure that you don't keep readjusting them, putting on the very first time in the correct way, and then you can utilize appropriately.
All right, so of course, appropriate infection control precaution procedures require a lot of practice to memorize all the steps and be reminded constantly of the best way to handle healthcare related situations. I just want to give you a few examples of what not to do, something that's very inappropriate and potentially very dangerous both for our patients as well as for the healthcare providers or treatment team in general. So what not to do. Touching contaminated materials with bare hands, absolutely no. Not washing or sanitizing one's hands after every interaction or procedure. Also, very, very dangerous, absolutely, to avoid sitting on the floor anywhere in a healthcare facility, regardless if you're in a unit, in an office, do not sit on the floor. Extremely important. As it is important, avoiding any use of masks and gloves or syringes after a previous patient encounter multiple times, even with the same subject. So you cannot enter a patient's room and take care of the patient, then leave the patient's room, go back to the team station, the nursing station, and then re-enter maybe 5 minutes later, the same room, the same patient using the same mask and gloves. Absolutely dangerous and inappropriate. And of course, something that should be common sense, but we should always remind basic hygiene measures, especially if we are healthcare providers. Entering your home, right? Entering one's home with the same clothes that you have been wearing during a shift, absolutely to avoid. So those are just a few examples that, again, are mostly common sense, but it's really, really important to pay attention to those protocols in order to, again, be mindful and practice infection control precautions appropriately. So this will be the end of the first part of this lecture. We will move on to the second part right away, and we will be talking right here about clinical, therapeutic, and medical techniques with a special focus on individual and group treatment. This, of course, is part 1 of this topic. So part 2 of this lecture, but part 1 for the whole course. Okay. All right, so let's begin with the areas of intervention. Mind-body medicine, a form of treatment which focuses on multiple aspects of individual, and the framework, the biopsychosocial model. We will talk about these two main concepts multiple times throughout this course. So just a few things to remember as part of this week's material. Now, when we talk about areas of intervention, we think about the whole spectrum of healthcare, okay? So the reason why in this course I included the term mind-body medicine is because we want to make sure to take care of all aspects of our patients. Patients as individuals, an extremely important philosophical concept. And how to do this? Well, we have to think about the biopsychosocial model, which is a model of care that, as the name implies, involves multiple perspectives. Certainly the medical perspective, so the clinical treatment perspective, as well the psychological, the sociological model, and of course the scientific in the context of biological model and the research. Now here below there are three main figures that will be at the center of our discussions in the next few weeks. The patient, of course. Any type of healthcare model should always be a patient-focused model. Keep in mind that as simple of a statement this might sound, we are there for our patients, not the other way around, okay? So we should always interact with our patient in a nurturing, welcoming way, as well as mindful of the fact that we have to speak in a way that the patient will understand. Okay? Very often the patient might be scared or at least intimidated to present themselves to a hospital because they might not feel, I don't know, maybe prepared or intelligent even enough to understand the jargon we might use. Again, we have to put them at the center of everything we do as healthcare providers. So patient is the first person in this context, in this biopsychosocial model we have to focus on. Then it's us, of course, providers in general, okay? And then the system itself, so the payer versus insurance. And we will talk about what type of healthcare system and insurance payment models there are in the world overall, globally speaking. But these three figures are a good start for our discussion. Let's move on to the next slide. So the question might be, again, so why mind-body medicine and why psychiatry? If we talked about that based on our textbook, why is there a need to include these very specific, and some of you might argue, quite narrow subfields of medicine in a course about healthcare in general? And this has to do with the main goal of this course, which is presenting a healthcare facility model which is structured upon the collaboration between multiple healthcare providers, professions, perspectives, and clinical interventions. Now, this means that a lot of information, perspective, and description pertaining to specific biological descriptions, practical application of norms, procedures, protocols for healthcare in general will be indeed discussed as part of either the slideshow, the PowerPoints, and the videos, or other added materials in the class, which is exactly what we've done in the first part of this lecture. Okay, so that part will be included in the slideshow. The textbook will be focused on these three main areas of analysis. Again, utilizing an inpatient psychiatric unit as a model to present the vast majority of healthcare-related clinical situation, as well as many healthcare providers, profession, and typologies of intervention. So three main areas of analysis in the textbook: A, individual and group therapy sessions; B, exercise groups, which of course are part of the mind-body integrative approaches to medicine and healthcare; and then C, group attendance and session standardization. Since healthcare also involves systems, not just patient-provider interaction, but structure, function, and organization, this is going to be very, very important. In part because it's a description of something that is already applied in a hospital. So these will be the main areas of discussion that the textbook will be focused upon. So when we think about our patients, since we mentioned that our patients are the center of everything we do in healthcare, we should think of how to identify our patient. What is the first model we can utilize to define a person as a patient, okay? When they first come to our clinic, to our hospital, to the emergency room, or in this context, to the inpatient psychiatry unit. Now, as an example here, I provided a brief list of patient information and identifiers. Starting with the medical record number, that has to do, of course, with the EHR, or electronic health record. The date of birth, very, very important not to make mistakes, especially for the ones of you that might have healthcare clinical experiences abroad. The date of birth is always reported as month, date, and year in the United States, and day, month, year in most of other countries in the rest of the world. Okay, so just keep in mind that something as simple as a date of birth has to be very specific so that you don't make a mistake in the context. Current age of the patient expressed in years, which also has to do with patient placement in the context of adult unit versus pediatrics. All right. Date and time service provided. Again, keep in mind that there are different ways to report time, whether you are in the United States or you're abroad. In the United States, generally speaking, we utilize the ante-meridiem versus post-meridiem model, so AM, PM, where ante-meridiem, it's the Latin form, of course, and post meridiem, it's the afternoon in the Latin form, versus something that very inappropriately is labeled as military time. Now, it's inappropriate to call it military time, not because of the label itself, but because very often it's mispronounced. So for instance, to give an example, 1 p.m. in the United States in any hospital should be written and pronounced as 13. All right, so 13, because it's the hour coming after noon, so 12. Very often, some healthcare providers that might not get the base 60 model might pronounce it as 1300. This is as common as it is mathematically wrong, okay? Because we're not talking about base 10, we're talking about base 60. And of course, the hours divided in 12-hour models, so 12 during the day and 12 more at night time for a 24-hour model altogether for the day. But because it's base 60, it does not make sense to say 1300, or even worse, when it's 1:30 p.m., 1330 or 1330. It's a common misconception that we're utilizing a base 10. It is not the case because, as we all know, 60 minutes make up an hour and 60 seconds make up a minute. So, and of course, minutes are defined as the minute part of the hour. So in Latin, that will be the first minute and the second minute, which in English became minutes and seconds. Okay, so the longest as opposed to the shortest one. So again, daytime service provided, we have to think about 24-hour clock on a base 60, right? And so when it's 1 p.m., we think of 13, okay? When it's 5:30 p.m., we need to think of 1730, all right? When it's, 8 p.m., we have to think about 20, okay? Not 2000, please, okay? Let's not make this mistake. And by the way, this is the time as is used in most of the remaining countries in the world outside of the United States. So it's really important to master this. We will talk about differences between the US system and the metric system as well. But for now, let's just focus here on the AM versus PM, AM PM versus the quote unquote military time difference. After this information, in any note, we have to identify the treatment team providers. A few examples here: doctors, physicians, social workers, nurses, etc., etc., etc. And then the description of the primary medical issue or primary psychiatric issue, and the chief complaint from the patient or reason for referral. And there are many ways to describe this information and provide more detail, usually through clinical notes, program notes, or the so-called SOAP notes that are utilized to describe the subjective, objective, assessment, and plan description for each of these notes. Now, this is just a brief introduction to the type of work in terms of documentation that healthcare providers will have to complete as part of their treatment, but we will, of course, provide a little more detailed information in the next few weeks. But for now, I just want to discuss the general structure of a standard inpatient psychiatry unit and a standard inpatient psychiatry treatment team. Because again, the reason why we utilize this as a model for our course is because this type of healthcare environment presents some of the most complex and diverse combination of multiple healthcare providers. And so this complex team will give you the chance to see how each of the members interact with one another. So this is the next slide that we also took from the textbook. So an inpatient psychiatry treatment team. Here you see a little model resembling somehow a pyramid. Okay, And again, the numbers here do not indicate any value or judgment of preparation per se. It's very important to understand that in any healthcare facilities, really in any healthcare system, each member is as important as the member above and below. Okay, this is not just to provide a overall philosophical description of the different providers, but it's really important to understand that no single treatment team member could actually be able to perform their job appropriately were it not for the remaining members. So everything is absolutely interconnected. Okay, so there's no better, worse, higher, or lower. Everybody works together. So on the top of the pyramid, we simply indicated the professional figures that for the most part has the broadest scope of practice, whether clinically defined and legally defined in terms of licensure or not. This will be part of a further discussion, but a very, very broad area of intervention. And in an inpatient psychiatry treatment team, this professional figure is the group therapist. Okay, so the group therapist, depending on which model and which country, really, also which state, and the reason why I mentioned which country and which state is also because not in every country do inpatient psychiatry unit exist. In some countries, there are prohibited by law. For instance, if you think about Italy with the laws of the 1976, the Legge Basale, Law Basale, that closed any locked unit in that nation, all right? But overall, group therapists are, for the most part, clinical professionals that are, at least in Vermont, rostered, so registered as psychotherapists. We'll talk about that in a few slides. So as far as the level in this model here, we define group therapists as level 3 or 2, which generally speaking indicates a master level or above. So level 3, a doctorate degree, or level 2, at least a master degree. And they are responsible for a full patient care, standard psychotherapy intervention. Here, CBT and DBT group indicates cognitive behavioral therapy and dialectic behavioral therapy, respectively, as well as individual psychotherapy. So the group therapists are really the only professional figures here that interact both in a single patient-based way as well in the context of a group. Okay, and they also involve integrated clinical approaches and clinical assessments for every patient. Right below the group therapist or psychotherapist, you find psychiatrists and pharmacists. Level 2, because the main degree here is an entry-level professional degree. We will talk about more about that. An entry-level professional degree can be, for instance, a MBBS or MD, so a medicine bachelor of surgery, or a PharmD, a doctorate in pharmacy or pharmacology. And these two professional figures are the experts within the unit of the pharmacological intervention. Okay, so medications, as well as some administrative components and the legal component as well, such as admission and discharge plan. Now, of course, the discharge plan has to be signed by the 4 main clinical treatment team plan figures. Okay, so in order: psychotherapist or group therapist, psychiatrists or pharmacists, registered nurse, and social workers. So psychotherapists, psychiatrists, nurses, and social workers are the core element of the clinical team. In yellow here, we see level 1, all right? Level 1 because depending, again, which state, the registered nurse will have both a bachelor in nursing as well as a license to practice nursing, okay, to be a registered nurse. Now, of course, in Vermont, things are slightly different. A person could be an RN without a BSN, but the law is changing. So in general, BSN RN is the standard of care for registered nurses. And it's also true that some nursing staff do also have higher degrees, such as a master degree, as well as DNP, for instance, a doctorate in nursing practices. But overall, the required degree is level 1, so a license and or a bachelor degree. And nurses are, in my mind, the beating heart of every hospital. Now, I do admit my bias because I had the wonderful opportunity to work with nurses on a daily basis, and they really do a lot for our patients. So they are certainly involved in the direct patient care as well as medication administration, following the orders of the psychiatrist and the pharmacist. In green, number 4, social workers or case managers, okay, depending on the licensing degree, label, and structure. Okay, level 2 or 1. So again, either bachelor level or master level as a starting degree. And as the name implies, they're responsible for the connection between the clinical work completed on the unit and any type of follow-up conversation with the world outside, so to speak. So follow-up and pre-post discharge plan, social and family interventions, working in cooperation with insurances, insurance representatives and policies, and so on and so forth. The bottom of the pyramid should be viewed as it is. It is the bottom as in supporting everybody else, not the bottom because of a lower quality or a lower description. I want to stress this again. Every treatment team member is important exactly the same way. Generally speaking, number 5 indicates MHTs, which are defined as mental health technicians, LPNs, LNAs, or US. US stands for unit secretaries. They do play a fundamental role in direct patient care. Now, while they do not provide clinical or medical intervention, they do not practice psychotherapy, they do not administer medication, they're essential because they're responsible for the safety of everybody on the unit, so that they are responsible for vitals, for checks, for certain administrative tests, for overall support to the multidisciplinary treatment team. Now, this is a general description, and I'll be happy to answer questions if any of you might want to embark in a career and would like to know a little more about this or that profession. All right. Now, the question is also not about the profession and the titles, but what are we actually studying? Okay, so just few description here for each of these areas. So the first word, healthcare, this is an introduction to healthcare, so the main word. What is healthcare? Healthcare overall is the organized provision via the prevention, diagnosis, treatment, recovery, or cure of disease, illness, injury, and other physical and mental impairments of care to individuals or a community. Many words here. We could spend an hour talking about the meaning of each of these terms, but for now, keep in mind that this is the broadest possible spectrum of intervention. Medicine, the art, science, and or practice of the diagnosis, treatment, and prevention of disease. Now, just a few things here. When we talked about art, science, and practice, we had to think about what we said previously about the Greek philosopher Aristotle and his definition of science. We talked about science as divided in 3 main areas. So science as episteme, from which we have epistemology, which is the theoretical study of science, the science of science, so to speak. Then we have knowledge as techne, which is technology, the tools, the craft of our profession, the things that allow us to practice well. And that's what we mean also by art. By the way, art and technology are connected. The ability to do something, to operate, for instance, if you're a surgeon, right? And the third element is phronesis or phronesis, which is very much connected to prudence or bioethics. And that's why medicine is all of this. Okay? It's science insofar as it is an applied science. Okay, a physician is not a scientist. He does not necessarily, at least based on the degree, produce original research is not a requirement necessarily, so he applies the scientific discoveries of medical scientists. Okay, so it's an applied science form. It's definitely a practice because medicine is connected to the direct intervention, but it can also be a discussion and theoretical analysis, and of course it has to be art because it requires a development of a certain skill to practice. Okay, we could talk more about the diagnostic part, all right, and whether treatment, healing, or curing are appropriate terms depending where we were headed here. But I would like to leave the philosophical discussion for the following weeks. So for now, just keep in mind that in the context of diagnosis and prognosis, the central concept here is gnosis or gnosis, depending how you want to pronounce it, archaic or more modern Greco-Roman background. Gnosis means knowledge, okay? So diagnosis really is the knowledge through or in between two main elements, two different perspectives, to analyze what the patient presentation is, okay, to decide really in clinical terms what the problem is, okay, that's a diagnosis. And the prognosis, as the name implies, of course, is what to expect in terms of the healing path for the patient. So this is healthcare and medicine. The third one, since we're talking about healthcare in general with a mind, body, and biopsychosocial model, is of course psychotherapy. There are many definitions of this practice, but for now, a brief description could be the provision of treatment, diagnosis, evaluation, or counseling services to individuals or groups for a consideration for the purpose of alleviating mental disorder. Now, this is also part of the overall description that the state of Vermont, the Board of Allied Mental Health, has for the practice of psychotherapy. So just to keep in mind that those are very brief definition of healthcare, medicine, and psychotherapy. Now, to go back to practice, so the practical application of healthcare in the environment that we briefly mentioned earlier, the inpatient psychiatry unit, it would be worth to discuss what each member actually is doing on a daily basis to provide this care. Now, this will also be a very long and complex conversation. Again, this is just an introduction to this aspect, so I will use a brief table in the next slide, a table you can find in your textbook as well, to define the main treatment team members and their respective workflow. So you can see here in black the patient. Again, always start with the patient at the center of therapy, followed by the registered nurse, followed by the psychiatrist, followed by the social worker, the resident, the mental health technician, and then the activity therapist. Quick note, the term activity therapist used to be utilized at the hospital that the textbook is focused upon prior to the application of the more proper group therapist label. Now, activity therapists and group therapists are exactly equivalent. The general term utilized nationally and internationally is psychotherapy. All right. So if you think about, in the context of this course, of activity therapists, you should think of group therapists as well as psychotherapists. Now, this is, of course, different from other professions such as occupational therapists that might not necessarily be either registered as psychotherapist or licensed as clinical psychologist, but nevertheless, for the purpose of this course, all these terms are equivalent, okay, therapist or psychotherapist. Now, the patient in black, the first thing that happens to this patient, of course, is entering the inpatient psychiatry department, the unit. Now, at this point, regardless if the patient has been brought to the unit through a direct admission from another unit at the hospital, especially the emergency room, or not, at this point, there is a general orientation as part of the admission process to the unit. Now, in this image, in this workflow table, the unit is defined as Shepherdson 3, which is one of the inpatient psychiatry unit, but it's true for all units, of course. And so as part of this introduction, in this orientation, the patient will meet everybody. Will meet the nurse, usually will meet both the patient's nurse for that very shift, as well as the charge nurse for that day. It will meet with a psychiatrist, and of course, if the hospital is also a university hospital, will meet residents and medical students, etc., and possibly the chief psychiatrist or the medical director, but we'll definitely meet at least one psychiatrist. We'll meet the social worker, it will meet the resident, of course, the mental health tech, and then the psychotherapist. Okay? Now, as far as the remainder of the workflow, every other treatment team member, except for the psychotherapist, will simply begin the treatment and meet with the patient on a regular basis, either daily or weekly. So that is pretty much the workflow for every other treatment team member but the psychotherapist. Now, this does not mean, of course, that every other member it's less involved. All right, so meeting with patients is associated with the type of work that each treatment team member does. So the nurse will meet with the patient several times during the day, for instance, for the purpose of administering medications. The mental health tech will meet with the patient several times for the purpose of assessing vitals, etc., etc. The group therapist or psychotherapist is very much involved with all the processes that are underlying an inpatient psychiatry unit. And those are very, very basic tasks that I included in this slide because there are many, many more. So this is really a brief summary, but I will just read it to you for clarity. So the first part is schedule coordination. In any inpatient psychiatry unit, because of the complexity of treatment, the psychotherapy is responsible for the creation and the appropriate changes or editing process to match the need of the patient. We will see what type of treatment, what type of strategy are utilized, but for the most part, what type of treatment, psychotherapeutically, psychologically speaking, the patient will receive on a unit, it's the job of the psychotherapist, of the group therapist. As part of creating the therapeutic schedule for the week, they have to verify who's working for the week, the expertise, of course, of each psychotherapist, because some psychotherapists might have further training, let's say in neuroscience or mind-body medicine, dance movement therapy, counseling, trauma treatment, addiction and recovery, etc., etc. Then decide, of course, which intervention, which therapy groups will be held for the week, create this group schedule, distributing the group schedule, and of course, as you can imagine, there are other tasks in between depending on isolation procedures or infection prevention procedure, etc., etc., or in the context of virtual meetings to prevent safety in the context of a pandemic, for instance. And then they have to prepare both the therapeutic environment, the therapy room, and then, of course, continuously meeting with the patients individually as part of a group. So a very complex workflow for the psychotherapist in comparison to the other treatment team members. But again, we're talking about a very complex and interactive treatment for all treatment team members. Now, since we talked about an inpatient psychiatry unit, I also want to talk about other types of professional treatments. There are many healthcare professionals, so this slide, it's very much a summary, but I just want to mention a few of them to give you a little introduction to this topic. So we have, in a simple alphabetical order, so not order of value or intervention, just alphabet, and a Latin alphabet in this context. Biomedical scientists, case managers, chiropractors, counselors, dietitians, doctors, insurance specialists, naturopaths, pharmacists, physicians, psychologists, registered nurses, social workers, surgeons, therapists, technicians, unit secretaries, and many others. Now, of course, this is a summary, and I want to keep the conversation to the point and focus on the most important elements here. But for a lot of these labels, we should have many other descriptors. I just want to give you a few examples to make the point here. Within counselors, a counselor could also be a therapist. Okay, it could be an addiction counselor, for instance. Chiropractors. In the United States, chiropractors are connected to chiropractic medicine, of course, and so they have specific doctoral degrees or entry-level degrees. All right. The same thing for naturopath. A naturopath might not necessarily be a naturopathic physician or a naturopathic doctor. Dietitians, we might have a registered dietitian, we might have nutritionists, and so on and so forth. So there are many other subfields and licensing description that we should mention, but this is an overall description. Something though that I feel it's important to mention right away is the part 2 of the description, because very often for a non-professional, for the general public, these 3 terms are confused. Very often people tend to confuse, mostly in the United States, but doctors, physicians, and surgeons, all right? And this is a very, very complex topic that I would like to be bring to your attention as we progress in our course, in order not to make mistakes and also not to assume things when some of you are still in the process of deciding which profession to choose if you indeed are interested in healthcare. So let's begin from the first one, okay? Doctor. So who is a doctor? So a doctor in general is a person who is a holder of a doctoral degree. Now, this doctoral degree, to be a quote-unquote full doctor, is either a PhD, Doctor of Philosophy, Philosophiae Doctor in Latin, a Doctor of Science, Doctor Scientiae or Scientiae, all right? Depending on which institution, you might find the acronym DSc or SCD, all right? Now, a doctoral degree is the highest academic and professional achievement in any field. In our case, of course, healthcare-related areas. Okay? So a doctor is the highest doctoral degree. Okay? It's the highest achievement. A physician, instead, is in general a holder of an entry-level professional degree. This term derived from the Latin term physica, which is the feminine singular of physicus, which is connected to the etymology of the word, which is study of nature, which in itself comes from the Greek physike, episteme, which is the knowledge, as we talked about earlier, right? Epistemology, right? Knowledge of nature. So a physician is the expert of nature. Now, the reason why a physician is in general not considered a doctor from the perspective of academic ranks, all right? It's simply because the degree is, depending on which country in the world you find yourself in, associated either with a bachelor level degree or with a master level degree. It's an entry level professional degree. It's not a high degree, right? Now, depending where you are, the general title that the degree holds is an acronym. So the most common acronym in the Commonwealth is MBBS. So Medicine Bachelor or Bachelor of Surgery. I shouldn't say or, it's a combination of these two. Medicine Bachelor, Bachelor of Surgery, because in the English-based model, these two terms are connected. So it's a bachelor degree. In the United States, overall, the term utilized is MD, Medicine Doctor, Doctor of Medicine, or Doctor of Osteopathy, in this context, osteopathic medicine, which can be confusing because very often an MD is confused with a real doctoral degree. Now, this has nothing to do with the level of education. You could assume that the level of education of an American, a US trained physician is as good as a physician trained in the United Kingdom. But what's interesting is that overall, for instance, when a physician in the United Kingdom is in the process of completing medical school, the person might not be referred to a doctor anymore. It will be referred, in the case of a male doctor, of course, as Mr., because the doctoral degree is only referred to the term upon higher achievements. Okay? Now, we could think of many other things in connection to the difference between MD and DO. For the most part, I just like to mention that the degrees are equivalent. Okay, so an MD is exactly equivalent as a DO in the United States from the perspective of both practice, diagnostic features, prescription, etc., etc. Although, to be fair, the Doctor of Osteopathic Medicine has more coursework, has a whole osteopathic medical treatment coursework on top of the standard coursework of an MD. So it's slightly higher in terms of the length. But then you have hybrid degrees, for instance, MD, PhD, which will grant the individual both a entry-level degree, so as a practitioner, as a physician, as well as a doctoral degree. And then you have surgeon, which is almost, I dare to say, the same as physician. In fact, the description is almost the same for the first part. In general, a holder of an entry-level professional degree. The term, however, surgery is from the late Latin chirurgia, from the Greek chirurgia, from hair, hand, and ergon, work. Think about ergonomics, if something is ergonomic, and think about hair or care for hand in chiropractic. Now, these three terms, traditionally speaking, were utilized to really indicate the level of achievement overall. Okay, so a doctor was the highest level, followed by the physician, and followed by the surgeon. Now, these definitions does not necessarily hold true. It's not true that, for instance, a surgeon, a specialist in cardiothoracic surgery, is less than a psychiatrist, for instance, okay? Or a neurosurgeon should be viewed less than a family doctor, okay? It's no longer the case because, for the most part, someone who studies medicine studies both surgery and the physique, episteme, right? But in the past, in terms of the history of medicine, the term surgeon was related to the hands-on individual, okay? Not the person who had necessarily the knowledge, the theoretical and scientific knowledge of nature. And by nature, we, of course, mean the human body, but it was very skilled at practicing incision and surgery, was the hands-on person, okay? And so that's why the surgeon was the lowest possible level within healthcare. Above the surgeon, you had the person who also had the theoretical knowledge, the research background, which was a physician, and only after a lot of practice, when the person was to be considered this revered, knowledgeable man, okay? Doctor, of course, it's a Latin term, so it's connected to docere, to teach, so connected to teacher, doctor, and teacher, right? That was the highest possible achievement, okay? Now, we'll talk more about that, but for now, just keep in mind that we should not confuse this term, because not to also to avoid miscommunication, etc., etc. So it is certainly fine for a physician or a surgeon to refer to themselves as doctor in a hospital overall, but this could lead to a lot of miscommunication in the context of academia. For instance, they had to present a scientific conference, and a person with a lower degree will use that term. All right, so next slide, talking about psychotherapy and integrative medicine, which is one of the very last topics in this lecture. We're approaching part 3, so we're almost done. There are many types of interventions that psychotherapists are responsible for in any hospitals, but in our context in the inpatient psychiatry unit. Again, these examples here are simply listed in alphabetical order, and since many of them have to do with complementary, alternative, and integrative approach, we will discuss them further in the next 4 or 5 weeks when we'll talk about mind-body medicine. But for now, let me just read it to you and give you just a brief description. So we have affirmation and gratitudes, anger management, art therapy, body awareness, CBT, cognitive behavioral therapy and cognitive processes, CFT, compassion-focused therapy, communication skills, DMT, dance movement therapy, dialectic behavioral therapy, daily goals and check-in, distress tolerance, drumming, relaxation, yoga, exercise, gentle movement, Focus, which is the patient satisfaction survey that is usually done once a week. Garden or nature therapy, grief and loss, group therapy in general, journaling, meditation, mindfulness, narrative medicine, and nutrition. This is just letter A through N. There are many things that we could say about each of these intervention. These are all conducted in a group setting, but many of these treatment can also be transferred to a one-on-one conversation or again psychotherapeutic session. In general, I would like to mention that in the West, at least in the United States, a lot of psychotherapy and clinical psychology is behavioristic in its approach. So it focuses on the two main areas of direct clinical judgment, so thoughts and behavior, right? So groups such as cognitive behavioral therapy, as the name implies, will help the patient work on their thoughts, cognition on one side, and their actions, behavior on the other side. DBT is the other standard of care, dialectic behavioral therapy, from the work by Marshall Linehan, and it provides an added, as it implies, dialectic component, well, subdivided into four main parts in the context of DBT, according to the model by Linehan, but still has a very solid behavioral and according to some behavioristic approach to therapy, which is something that is overall considered the standard of care simply because it gives the practitioner the ability to work with the vast majority of psychological problems a person might suffer from. But then we have specific training that is required, for instance, in the context of art therapy. In the United States, the American Art Therapy Association is responsible both for training and licensing elements to become a registered, licensed, board certified art therapist. In many cases, again, depending on the geocultural area and the state rules and regulation, an art therapist could also be a psychologist or vice versa. A psychologist can further specialize in art therapy. Sometimes art therapists are mental health counselors, etc., etc. The same thing for other groups that are connected to expressive arts, for instance, dance movement therapy, DMT, board certification, registered art, DMT. It's one of such licensing possibilities in the United States. And then there are groups that are broader and yet deeper sometimes in the philosophical component that they present as part of their treatment. For instance, grief and loss, that target, as the name implies, different ways to approach this sorrow and suffering. For instance, just to give an example, the 5 stages grief model, and a connection between grief and loss in connection to the spiritual care department, for instance. So in the context of the 5 stages, of course, the model by Elizabeth Kubler-Ross, and in the context of loss in general, a discussion on transcendental and philosophical elements, spirituality and religion, if the patient is interested in this offering as well. And then we have more administrative groups that are less treatment focused, or let me say less directly in-person treatment focused, such as a focus group, interestingly enough, because the patient satisfaction survey, so to speak, involves a necessary sets of questions as part of this questionnaire that are also meant to provide a place for the patient to express either concerns or thoughts regarding to their treatment, but also ways to be able to adapt the treatment to the patient's need that might change. For instance, in the context of other interventions in patient psychiatry units, such as ECT or electroconvulsive therapy, we might have to adjust certain groups or the content of certain groups, or we might decide to utilize different handouts and worksheets as a follow-up to the preference of the patients themselves. We can talk more about each of these treatment modalities, but I have another slide for the remainder of the alphabet, letter O through T. So let's do this, and then we'll move on to the next topic. So few more examples here. This is a very small and brief extract of everything that group therapists do in a inpatient psychiatry unit, just to give you a general overview. Open arts or arts and crafts, which is very different for art therapy. Art therapy, by definition, has both a clinical, diagnostic, and therapeutic component that is absent or not necessarily present, let me say, for open arts and crafts. REBT, rational emotive behavior therapy. Recovery group, which can also be associated with addiction and recovery group. Very often we have the opportunity to work with AA, so Alcoholic Anonymous, or NA, Narcotic Anonymous volunteers. And we you know, of course, we as treatment team members, we also have the opportunity to have patient advocacy groups, etc. So we have interactions with the outside world in the context of any type of recovery. Personality type, pet therapy, again, extremely important. Also, usually conducted by volunteers under the supervision, the medical clinical supervision of both, group therapists, psychiatrists, and the team. Poetry, self-expression. Relapse prevention, very often in combination with recovery group. In general, group therapists focus on three main areas when we talk about addiction and recovery. We talk about, again, standard of psychotherapeutic care, so CBT, DBT, and then we focus on basic neural underpinnings of behavior and what kind of underlying neurological mechanism we have to discuss to better understand addiction itself. And then the third part, of course, is the human connection, we could say, the experiential connection as part of, for instance, volunteers that had the opportunity to meet with the patient and talk about their own experience. We have many research-based interventions. For instance, another perfect example for healthcare in general is the research on olfactory virtual reality conducted in patient psychiatry that, as the name implies, involves a variety of healthcare professionals from neuroscientists, neuroengineers, psychologists, psychiatrists, etc., to provide a very broad spectrum of intervention in this context, mostly focused on olfactory and visual cortex stimulation for the purpose of amelioration of treatments and reduction of anxiety and stress and perception of pain. Seeking safety, extremely important, because we still want to make sure to address the biopsychosocial model, right? So again, since we talked about the complexity of reason why an individual might be admitted to an inpatient psychiatry unit, we also want to make sure to address social issues and family problems that might be triggering or might be an essential component, even with causal factor to the current presentation, especially so upon discharge. So we want to make sure, in collaboration, of course, with the social worker / case manager team, to address that part as well. And then we have group about reconstructing, rebuilding, reframing, recombining self, so self-esteem, self-image, self-reflection. We have groups that are skill-oriented, skill-based, such as solve that problem. So we want to utilize this depersonalization component, and by that I do not mean it in a clinical sense, but I mean depersonalization as less focus on the person and more on the problem that we need to solve. So that person might be more prone not to negatively judge themselves and blame themselves for their issues, but to externalize those issues. Spiritual care, as we mentioned, stress management, very important, that is usually offered in combination with the previous groups: relaxation, meditation, mindfulness. Supportive relationships, very often in combination with DBT groups, right? As you know, as obviously so, given the four main elements of DBT, Tai Chi Chuan, and then teaching. Now, teaching is also very important. basic pharmacology and neural underpinnings of behavior, because depending on the specialization area of the group therapist or of the psychiatrist or the pharmacist or the nurse or the social worker, those interventions are generally providing a more in-depth answer to certain questions that the person might have, that the patient might have about this or that area of their treatment. So this is to conclude part 2 of this lecture. I would like to ask your attention for a few more minutes to venture into the very last part of this week class. And the last part is the discussion on current healthcare system and trends. I will also recommend to review a lecture video that I will include in the link below, mostly on the philosophy of history of healthcare in general, the philosophy and history of medicine in general. So this part will be very brief, just a few slides to conclude, and also to summarize what we said so far, especially about the structure. Now, when we think about introduction to healthcare, let's begin with the 4 major types of healthcare. Okay, so we talked about the definition of healthcare, but let's see how this definition in practice works for the individuals that are benefiting from healthcare. Number 1, number 2, number 3, number 4, almost synonymous with the term, because we're talking about 1, primary, 2, secondary, 3, tertiary, and 4, coronary care. So pretty much an exact definition of what it is about. So primary care, as expected, the first and most generalized check visit for symptoms and medical concern. That's what we mean by primary care. The secondary care is the referral to a specialist for further investigation. The tertiary care is the higher level that very often requires hospitalization or surgery, for instance. Okay, and then some scientists add number 4, but the coronary care is really an extension, even higher level of specialization in comparison to number 3, so extension of tertiary care. So those are the 4 major types of healthcare with their labels. Now let's move on to the 4 major healthcare models. There are many, I would say, hybrid models in between, but for the most part, when we talk about healthcare and insurance models, really, we talk about these 4 main types. So the first one is the European model, also called the Beveridge model, which is funded by taxes, by public taxes. So the government acts as the single payer, removing all competition in the market to keep costs low and standardize benefits. This is the model throughout the European Union, in most European Union countries. However, the German model, the Bismarck model, number 2, is a hybrid model. So employers and employers are responsible for funding their health insurance system through sickness funds. The number 3 is the national health insurance model, which is like the European Union / Beveridge model, in the sense that the government acts as a single payer for medical procedure, but this national health insurance model follows the Bismarck model in the sense that usually providers are private. So this is another combination, a hybrid model between the European and I would say the German model from Otto von Bismarck. That's where the name comes from. The 4th model is the less effective of them all, the out-of-pocket model, which defines a model in which patient must pay for the procedure out of pocket. This is unfortunately the common model in less developed areas and countries such as the United States. And the research has indicated that it's usually the least effective model of them all, also to provide care to disadvantaged and vulnerable populations. In the next slides, we will talk about, again, the healthcare models from the perspective of healthcare professionals, and then the very last slide will be healthcare model in the context of clinics, healthcare facilities, and ambulatory facilities. So this slide is a brief review of what we said earlier about the differences between doctor, physician, and surgeon. But this slide is a little more specific as well as broad because it involves every other healthcare profession. Now, again, there are many different types of profession and degrees, so this might be a little bit overgeneralizing, because to compare degrees obtained in the United States and other American countries, such as, in North America, Mexico and Canada, outside of North America, think about Nicaragua, think about Venezuela, think about Brazil and Argentina. Each model is slightly different. And the same applies, of course, to the European model, within the European Union or outside of the European Union, the Eurasia continent, so the Russia, and the higher education system was really developed during the Soviet Union and the former Eastern Bloc that still follows that model. So there are some differences, but for the most part, this is a general overview that provides a quite precise way to at least understand the levels of such degrees. Now, this is applied to healthcare facilities, especially within inpatient psychiatry unit, to follow the conversation we had previously. So let's start from the bottom of this table here. On the bottom, we find administrative staff, management, students, volunteers, or intern. Now, the reason why there is an NA not applicable for degree level and no for multidisciplinary treatment team member, okay, so if you see on top, there are four main categories: degree level, title, type of degree, and whether the person is a member or not. The reason why we have this no, non-applicable, is because in terms of degree level, the requirements vary very much depending on the facility. So managers do not necessarily have to have any higher education degree. And the same thing applies to other administrative staff. So you might have, for instance, a technician with a high school degree or with an associate degree. Sometimes they will have higher degrees such as bachelor's and master, but there are no requirements. And in general, they're not technically part of the treatment team members, because either they're part of administration, so that they work on the administrative organizational parts of a unit or a department, so they do not take direct part in the patient care of the unit, or because, as we mentioned, are mostly focused on administrative tasks such as unit secretary type of work. So non-applicable because it's not required. Right above, you have assistants and technicians that usually, contrary to some of the volunteers that are not completing their degree, might have the opportunity to utilize a degree for support areas. Again, it's still non-applicable because even in this context, it's not a requirement, and in any case, they're not part of the treatment team. The very first figure, that professional figure within healthcare is part of a team, is, as expected, the nurse, the registered nurse, which is overall a holder of bachelor level type of degree. We mentioned this previously. In Vermont, at least for now, the requirement of a bachelor degree was not implemented, so the license was, so a person who wants to work as a registered nurse indeed needs to possess a license, an RN license, or higher licenses, APRN, for instance, okay, or other certifications and specialization areas. But on top of the license, this person might have a Bachelor of Arts, a Bachelor of Science, a Bachelor of Nursing Science, or Bachelor of Nursing, etc., etc. So degree level number one, okay? This degree level, by the way, were described as the higher education framework called the process of Bologna, or Bologna process, from the Italian city of Bologna, Bologna, where the first university was created. Okay, and so that model is the model utilized throughout the world to define the level of degrees as well as the credits required for each level of degrees, so bachelor, master's, and doctorate. So degree level 1, registered nurse, bachelor level. Above the registered nurse, you have the three main areas of professional specializations. Okay, level 2, pharmacists, physicians, psychiatrists, psychologists, psychotherapists, and social workers. Now this is tricky because there are some physicians and psychologists that are also doctors. Okay, the same applies to some social workers that are doctors, or pharmacists that are also doctors. But in terms of the treatment team, this is not a requirement. It is also true, as we said previously, that some physicians might not have a master's degree, they might have a MBBS, so they have a bachelor in medicine. But as far as their license perspective, this will still be equivalent. Okay? Number 3 is the doctors. Doctors are PhD providers, which again can be doctors on top of being physicians, on top of being psychologists, on top of being psychotherapists, etc. And they too are member of the treatment team. And the highest level, as the name implies, is higher doctors. And the higher doctor really defines a higher doctoral degree or higher doctorate. Okay. Now, in general, depending which one you follow, this title is either DSc or Acad. Acad stands for academician, which is a title and or academic rank assigned to a person who has at least a doctoral degree, and on top of doctoral degree has further specialization or extensive scientific peer-reviewed research, as well as faculty positions, etc., etc. So the DSc originated in Europe, in general in Central and Southern Europe. This doctor was equivalent to the Habilitation in Germany, or Habilitation in France, or Abilitazione in Italy, which, as the name implies, is a degree that allows a person with a previously obtained doctorate to conduct research, lead a lab, and teach in university in a doctoral program. The equivalent in the former Soviet bloc, in Eastern Europe, in countries such as the Czech Republic, Poland, Russia for sure, the Ukraine, the countries part of former Yugoslavia, is Dr. Nauk or Dr. Nauka or Dr. Nanaukita in Bulgarian, depending which Slavic language you pick. And they are all translation of the term Doctor of Science or Doctor of Sciences. Now, to be fair, a Doctor of Science can also be awarded as a lower degree in the United States. So some university will award a DSc or CSD with no further training. So the term will be equivalent to a PhD. And in those cases, the holder in general is awarded internationally title of academician or ACAD, academic. All right. So this is the type of degree for the professions that we discussed so far. The very last slide for today has to do with types of clinical and or ambulatory facilities. Again, even in these slides, the conversation warrants many other added description, but this is overall what I would like students to remind. The sources listed at the bottom of this slide. Let's start from imaging service facilities where imaging services such as X-rays, MRIs, and CT scan and ultrasound are performed. Below, specialized outpatient clinics, facilities for providing care in specialty areas such as cardiology and urology, among others. Ambulatory surgery centers, or ASC, facilities that specialize in same-day discharge of patient post-surgery. ASCs can be either hospital-associated or freestanding. Urgent care centers, facility that provides medical services for patients needing immediate care for certain lower acuity illnesses and injuries that do not require a trip to an emergency department. Emergency departments, of course, also known as emergency rooms or ERs, they provide a broad range of emergency services to higher acuity patients. Now, keep in mind the primary, secondary, tertiary, and coronary care The four major types of healthcare in the context: primary care clinics. These are settings where patients are seen by the primary care physicians. The acronym is PCPs. Retail clinics, also known as convenient care clinics. These are walk-in clinics offering preventive health services and treatment for uncomplicated illnesses. And finally, community health clinics typically offer primary care services to patients with limited access to healthcare, including homeless individuals or migrants, and patients with low income or no health insurance.
Wonderful. This concludes week 2. Thank you very much for your attention, and I will see you all next week.